I'd like to introduce to you Robin Bew. Robin is the West Region leader for EY's Center for Board Matters, which is the firm's corporate governance practice. And so without further ado, Robin, I'll turn it over to you. Thank you.
Great. Thanks, Mark. Great to have everyone here with us this morning and looking forward to a really interesting and really timely discussion. I think in the session description, it said something about, every company is a healthcare company in some ways, regardless of what industry you're in. And I think that that's going to be something we're going to really have a good time exploring with our terrific panel, who I will introduce in just a minute, and with all of you. A couple of just notes in terms of how the session is going to go. As Mark said, please feel free to put your questions in the chat. We'll be monitoring that. We will, be pulling in some questions perhaps as we go through the discussion, and we'll definitely leave time as well before we wrap up, just to try to take as many questions as we can. So look forward to those. Also, want to remind everyone that we'll be using a confidentiality ground rule here today. So we encourage you to share your lessons learned, your key takeaways from the discussion today. We just ask that you not attribute those to any individual, to any company, and that way we can have a really candid conversation. The same thing with posting questions. So let me introduce our panel briefly, and the full details went out, so you have everybody's full bios in the materials that went out from NACD. Chitra Nayak sits on the boards of Infosys, Invitae, which is a genetic testing company, and Forward Air Transportation. Dan Lillienquist is the Chief Strategy Officer at Intermountain Health, and also is a board member as well. He sits on the boards of Graphite Health and Civica RX. And my colleague, Mallory Caldwell, is EY's America's Health Strategy and Transactions Practice Leader. So really interesting and diverse set of experiences that we've got with our panelists today, which is really going to help us get into the issues. And that's where we'll go right now. So to start off with, maybe we can set just a little bit of context about the current state of play with healthcare in the U.S. And that's a big topic and it's complex, but I think we've all sort of seen some of the structural changes, maybe not new, but they're really kind of coming to a head. We all know about the population is getting older. There are more retirees. There are fewer workers. That's impacting things. Certainly the long tail of the COVID-19 pandemic as well. And so obviously all these things are relevant to companies in every industry, not just in healthcare. So Dan, maybe I can start with you. The call that we did the other day, you talked about the supply and demand imbalance, particularly within the healthcare industry. That's also a really important issue, for company leaders, for boards to be aware of. So maybe you could start with that issue.
Yeah, absolutely, Robin. And thank you. It's good to be here. I'm Dan Lillienquist, and I'm the Chief Strategy Officer of Intermountain Health. And for many of you, you may not know what Intermountain does, but we're a large integrated delivery system in 7 states, and we are on the forefront of healthcare delivery. And what keeps me up at night as a chief strategy officer, in the next few years, the model of healthcare is going to need to change. And just to give you an example, we are facing the first time in human history we've ever had this many people entering retirement. We've had about 10,000 people a day aging into Medicare over the last 7 years. And over the next 5 years, the baby boom generation will continue that trend until they're all retired. And the biggest challenge is when you have a shift to the right in that service. I mean, if you think about the elderly, they are by far the most complex and difficult to serve. And Medicare Advantage patients, Medicare patients aren't expensive at 65, they're expensive at 75. And now the baby boom generation average age is 71, and they're going into the most expensive part of their journey and complex part of their journey. At the same time, a full quarter of the doctors and nurses and caregivers are also in that same age demographic. And so we're expecting not only a huge increase in demand for healthcare services, but at the same time, an unprecedented retraction in the supply of healthcare services. And at Intermountain, we've done the math here and been looking through this. We hired every single doctor and every single nurse out of every single program in all of the 7 states that we operate and retained 100% of them. If our care delivery model doesn't change, we will be thousands of providers short. And so we're really trying to think through is how do we meet the needs of our communities and as a nonprofit organization and face this next 15 years of what will be an extraordinarily stressful time for healthcare. And the great news is there's a lot of optimism that some of the new technologies that are coming out will allow us to do this more effectively. And maybe that this unique moment of crisis will help us build something that's more scalable, a better, more reliable healthcare system. The last thing I'll say on this, Robin, and of course, this will be a big part of the discussion. I know Chitra and Mallory will weigh in here as well, is that the traditional one-to-one doctor-patient relationship is one thing that is going to be a casualty of this time. There is just not enough providers to continue that older model. And so you'll see health systems like Intermountain and others really lean into team-based care, lean into AI models that help us do better predictive analytics on who needs us to intervene and when, and looking to be much, much more proactive about the care we provide to our members and patients and customers. And hopefully with those new tools, that'll give us a more resilient, more responsive, more effective, frankly, healthcare delivery system in the coming years. But there's a lot of work to do to get there.
Thanks, Dan. Thanks for teeing that up. And you've given some good sort of teasers, previews for we're going to turn in a few minutes to some of the really exciting developments that are here and coming soon. We'll pause that for now. I want to stay for a minute with just kind of talking about the current sort of state of play. Good, bad, and ugly. I mean, the supply demand imbalance, Dan, that you talked about, and I think for all of us here, when you hear what you just said, the one-to-one doctor-patient relationship may be going away. I mean, I think that gives, let alone for our boards and for our companies, but for all of us as individuals, that kind of gives us pause, I think. Mallory, I want to turn to you here. I know you also talked about sort of looking at that demand side. The other issue, so we've got the scarcity, but also, all of us consumers and the employees in our companies, we're not really getting what we want. And there are some other issues as well around sort of trust and access that you talked about. So maybe if you could touch on those to kind of help with this.
Yeah,
sort of
happy
state
to
of
do
play.
it, Robin. So it all fits neatly with what Dan was just outlining. We've got this increased demand for services. We've got this, cliff of supply of providers that's begging us to change. In addition, everybody as a consumer wants it to be different. Everything else in our life has become immediately accessible, very clear sets of choices, transparency on cost, immediate personalized recommendations. When I land at the airport, it says, would you like to go to the Marriott downtown where you went last time when you landed? It knows me. These are completely different experiences in everything else we do today than what we have in healthcare. Every time I walk into the doctor's office, there's a new set, the same set of questions, not a new set of questions, the same set of questions as if they've never met me before, right? There's not choice about how I'm getting it. There's not transparency of what it's going to cost. It's definitely not immediate. So you can just see the point and counterpoint. And so we as consumers, and this is true, by the way, we survey this at Ernst & Young. It is true across all age demographics. So the seniors also want it to be different, but especially the working age mom of the household who's making decisions for parents' care, families' care, children's care. They want this to be different. So it's begging us to change. So we've got all this. We're consuming more health. We're, relying on the beleaguered workforce to try to get all that done. The hard truth is there's places that we're not making progress. There are continuing disparities in health outcomes that are absolutely predictable by race, by rural versus urban environment, by marital status, certainly by socioeconomic status. So we're doing all of this work without creating a healthier population. And so again, begging us to change and to work differently. There are lots of silver linings of people who are, and I know we're going to turn to that, who are making those changes. I think the forced experiment of COVID, of trying new things, has opened people's eyes to the possibility that there are different ways of working. Necessity being the mother of invention, relying on the social caregiver to provide more care at home and rely less on the formal caregiver. These are structures that need to create, that need the support of formal structures to really let us live into those, to the potential of those. So lots of silver linings. With the silver linings to come, the hard truth is we're trying to reinvent the healthcare system at a time that the people working in the healthcare system feel like they've been run over by a truck. We've been through a global pandemic. We've been through the Great Resignation. We've been through an upheaval of economics where every health system was losing money. Almost every, in air quotes, health system was losing money a year ago. They've come out the other side of that and they say, we really want to lean in to do this differently, but they're leaning into it with a workforce that's just tired. So I know we've given the, up to your elbows and alligator story here, but that is a little bit the answer to the question of tell us about the current dynamics in healthcare.
Yep. Anything else either of you would add before we turn to some of the optimistic, some of the innovation that's happening, just in terms of access and trust issues. I think that was something we saw sort of coming out of the pandemic as well.
I'll just, you teed that up before and I didn't really answer it. I think a lot of those disparity issues fall down to access issues and trust issues. Some of it is access. Not everybody in our communities has the same access to care as the next person. You see that in socioeconomic issues. You see that in rural and urban issues, divides. And then there are very real trust issues. Each of us individually has a different barometer on this. How do I go to the doctor? How do I include them in the reality of what's happening in my life? There are some definite racial trust issues where just later diagnosis of issues because lack of engagement with a system that lacks trust. And then with later diagnosis, we have, more expensive care, worse outcomes, all the things you don't want to happen.
So despite all those challenges, Dan, as you said earlier, this actually is a really exciting time to be in healthcare. And so let's take a look at some of the innovation happening. And we could have done the whole call just on this topic in terms of all the really exciting and meaningful, not just cool, but actually making a difference use cases out there. But let's spend a little bit of time on that, and obviously we'll talk about technology, we'll talk about AI and some other things. Chitra, I know on our call you mentioned a couple of examples that you're seeing from the companies on whose boards you serve. So maybe I can ask you to kick us off here.
Yes, an interesting transition from the previous topic, though, is the mental health situation, which has come to the fore. It existed, but it had not been as prominent for the past X years. And if you think about what happened, technology is always about that quote, move fast and break things. And what happened was a lot of companies came up with purely digital mental health solutions. I was on the board of LifeWorks that actually had a terrific digital mental health solution, but now actually some of them are flailing because it needs to be human augmented, right? There's a spectrum of mental health that starts with can you start digitally? Great, you can save time and resources, but then do you need a human in the loop if it advances to a point you need somebody? And so that's why it's interesting to look at technology now, a lot of opportunities, a lot of innovation, but really needing to apply the lens on both sides of that to say what are the risks that come out. And I know we'll discuss that later, but just, one example that struck me as you think about the future of healthcare. there's lots of very exciting things happening. So Infosys, which is an IT services delivery company, has a Tech for Good arm that is working on an app that anyone can hold up to their eye and get a read of the health of their eye, which, if you think about places like India and other remote locations all over the world, would let somebody understand from measurements that your phone is taking off your eye and analysis what the health of your eye is, and should you go see a doctor. There are other examples. Genetics, one of my boards is in the genetics field. And as everyone has heard about the whole drug discovery process, definitely the gene therapies, there's something called a VUS, which is a variant of uncertain significance, which makes it harder to read your gene sequence. And that has accelerated enormously with the advent of of AI and technology overall. So I could go on, as you said, forever, and I won't. But there's so many examples. I was just talking yesterday to a senior executive at Kaiser who talked to me about a startup that has a digital twin. Now, I'd heard about digital twins in cities and digital twins in manufacturing, but this was the first advent for me. I'm sure the rest of you are more familiar, Mallory and Dan, about how relevant it could be to that. So let me stop there and let others chime in.
Great. Dan, Mallory?
Well, look, it is very exciting. I do think technology will do a lot. If you think about, and I may have used this example when we talked, Robin, but I have IgA nephropathy. I have an immunoglobulin A nephropathy, kidney disease. And it's funny, it's very stable. I've had it since I was 16. I've had it for almost 34 years. And it's funny, as I go to my doctor every year and I try to sit as close to her as I can when she's reviewing my chart, because her eyes get really big. She looks at my chart, she looks at me, and she looks back at my chart. And that's when I reach over and pat her on the arm and say, it's okay. My creatinine clearance is this, my albumin is this. I go through my own chart. I know my own data. And I said, yeah, I know I have 60% of my kidney function, but I've had it for the last 34 years. And she takes a big, deep breath and she's like, oh, good. How's your family? And then we move on. And she listens to my heart and then charges me $250 and I leave. And I do that just to get my very simple losartan blood pressure medication, and maybe half the people on the call are on losartan. That's my treatment regimen. And it keeps my kidneys in good shape. And it takes me 6 months to get onto her calendar to see her, to have that little touch base on something that, frankly, had I had my labs done and my urine test done, an AI algorithm could have just reviewed my previous history and said, hey, you're very stable. This looks like it's working well for you. Let's renew this without having to clog up to, Dr. Lau's investment, her schedule. And she has people who are in full-on kidney failure, and I shouldn't be taking up one of the slots on her calendar. And so what's exciting about some of these new tools is we become more situationally aware as new data is ingested, as these large language model, generative AI techniques and tools become more available. We will be able to see patterns in healthcare data that allow us to manage larger and larger populations without having a requirement to see a doctor for every little thing. And that's what I say is the technology leaps forward are coming at a perfect time to reimagine what healthcare looks like. Last thing I'll say on this is my dad is an endocrinologist, and he retired a few years ago. He's 84, but I watched him practice medicine for 40 years, and he essentially ran the equivalent of a diabetes Jiffy Lube. He would come in and he had 10-minute slots with his patients, and he was so busy. But much of what he did was just looking at lab results and having a quick conversation with the patients, and titrating medication for his diabetes patients to try to make sure that they were managing their A1C better. A lot of what he did was now we can do digitally, and he could be really focused on the cases that required more than the 10 minutes he could afford to give them. And so as we're thinking about rewiring the work for our clinicians, it is the digital enablement with these tools. We will have our clinicians, our doctors, and advanced practice providers really focused on the more complex cases where time with the patient is critical. And so this should be a model that works better for clinicians, be better for their lives, where they're not just jumping on a treadmill every day and seeing 50 patients and trying to keep up, but to be able to focus more on the people who really, really need their help, while decanting a lot of the clinical volume that we've had go through these clinics and handle that in a different way. So really excited about that. The Intermountain is leaning heavily into those areas. We're very optimistic about the convergence of the necessity to change and the tools to make this even better for our patients.
It's great. You know,
Is it too
while
much for me?
we're, Mallory,
Is it
go
too much
ahead.
for
And
me to
then
do one more, Robin? Just building
no,
right.
please do that. And then I see there are a couple actually questions that are kind of all clustering around transformation on the insurance side. So I want to come to those, but Mallory, go ahead and then we'll get to that.
One of my examples will help tee up a little bit of response over there too. I'm excited about the emerging new care models that are out there. They're enabled by things that Chitra and Dan just talked about. I'll give two examples, and they actually sort of pull in different directions, but they are both really different from the traditional model. So one of them is a labor-intensive primary care model. Direct primary care is what people typically call this. One of the examples of this is Everside Health out of Denver, where they go to a self-insured employer and they say, we'll come in and we're going to put clinics for your employees and their families right here in the lobby of your building or right down the street near your business. And you're going to spend more on primary care than you've ever spent on primary care. We're going to really engage your employee base and their families. We're going to talk to them about their real health and their health status. We're going to really practice preventative medicine to stave off the adult onset of chronic conditions that we know are happening in your working age people. We're going to really invest in this concept of preventative care. The guarantee that they provide is that as a result of that, of really investing in primary care for this defined population, preventative care for the defined population, we're going to lower your overall cost of care. You're going to have fewer people showing up at the hospital. You're going to have fewer people with diabetes or whatever the condition might be in your workforce. And so your overall health expenditure as a self-insured employer will go down. They're doing it. They've got a money back guarantee that they will do that or you don't pay the fee. And they are winning at doing this time after time. Now, in the scale of our overall health ecosystems, it's ankle biter scale. But it's an experiment that's working. Okay, on the other end of the spectrum is a digital first model. The idea is that 80% of things that we go to the doctor for can absolutely follow a Q&A algorithm with the patient. And there's no reason that a robot can't ask those Q&A in a robotic process. You know, where do you feel the pressure? Do you have yellow discharge from your nose? When you bend over, is it greater? Wow, we think you've got a sinus infection. And then they've got a doctor overseeing the conclusory results of this Q&A process that's run by a robot, meaning that a doctor is seeing a whole lot more patients than you could see in the model Dan was just talking about for his father in 10-minute slots throughout the day. It's more efficient for the patient who just dialed up on their computer. It's more efficient for the person paying for the care because that is a lower cost care model. Again, excited to see these things being real in the market, showing proof of concept. And you're going to pose the questions here that are in the chat. But one of the things that I think people can be doing as CEOs of organizations and as board members is pushing to say, how can we take advantage? How can we help enable these alternative care models that begin to evolve the traditional model to something that is a more cost sustainable, more consumer friendly, potentially more effective. By the way, if you do the robotic algorithm on evidence-based practice, you get rid of the human error of the nurse practitioner that failed to ask the right series of questions. Potentially more reliable set of methods.
Yeah,
Right.
Mallory, it's interesting you say that because I think back to, again, many years ago when I was at Salesforce talking to the chief HR officer, there was this question about healthcare costs and the cost of insurance. And HR at that time, at least, was viewed as a cost center which made it near impossible to manage it the way that you're describing, right? And so that move towards how do you think about the full cost? As you think about software, you're always talking about the total cost for the lifetime of that product. Similarly, if companies were able to frame it more in that full cost version, I would imagine your answers could start to be very different.
Great point. And starting, getting what are some questions that, board members that CEOs can come and take back, and maybe be a little bit more of a demanding customer to those insurance providers. So turning to that, again, a couple questions in the chat that all are around, the fact that, we all see it, the costs are just continuing to go up and up. And so are any of you seeing some transformation, some new practices coming around on the insurance side to help, as Julie's question says, support optimal delivery, and eliminating some of those non-value add? How are insurance companies starting to change, if at all?
Maybe Robin, I'll take a swipe at that to start with. Look, and I'm thinking of this from a large employer space to a smaller. It depends on the insurer. I'll tell you the three large national insurers. When you talk about a commercial population, and most of, I think the folks on this call are on boards of businesses, and so a working population, not the Medicaid population or the Medicare population. Over the last decade, and largely in response to the Affordable Care Act passage, more and more employers have moved to self-funded, where the unpredictable nature of an insurance premium, it's not really insurance if the next year you keep getting, 9% to double-digit raise on your expected costs, and largely what the large national insurance companies are doing is they're just selling you a network of doctors. They give you a laminated insurance card and they say, we'll process the claims and good luck, go find what you need. And so, that's a recipe for, making it very difficult for people to know what to do and where to get care, but also tends out to be very expensive as well. And, the levers that these large payers have, they pay every provider on a transactional basis. And so it's really, really difficult to get somebody to move upstream, take care of a patient's pre-diabetes, when you're paid transactionally and the rates you're paid are so low that you can't make it work. And so the models that Mallory mentioned, for example, of having primary care focused, what we would call at Intermountain, proactive care models emerge, where they go directly to the employer to say, let's figure out how to work with you directly, because you're bearing the risk. The insurance companies are ill-equipped to actually help you manage that risk. The way they help you manage that risk is basically deny claims that are submitted to them, or delay payment, or try to just negotiate a race to the bottom on reimbursement or on payment to the providers. At Intermountain, what our strategy is, our mission is to help people live the healthiest lives possible. And what we focus on at Intermountain is we want to take full clinical and financial accountability for populations of people, believing that in a prepaid model, every time we can keep somebody on their medications and avoid type 2 diabetes, which is a preventable disease if you're managing it right. Every time we're engaging with early cancer detection, et cetera, and treatment, we add longitudinal value, obviously for the patient, obviously for somebody who can live a healthier and better life, but also for the employer. And what we've been working on is again, the trend has been moved more and more towards companies just saying, we'll just use an insurance company like a United Healthcare or a Cigna or an Aetna as a claims processor, but we're bearing the risk. We're developing new models to go directly to those employers and say, look, we'll guarantee you same day access for anybody who needs to see a doctor. And what we'll also do is build programs to manage the longitudinal health of your patients, of your own employees, because that's in your interest and it's in our interest. And we're working on subscription models that allow them to buy a subscription into our service, and then we will proactively manage the care of their patients. And again, that is such a fundamental shift in how healthcare has been delivered. But that's what it requires. And right now, you cannot effectively manage the long-term health of your employees in a company through transactional payments. You've got to have a different model, and those models are beginning to emerge in such a way that I really think it'll be large employers who really help transform how healthcare is delivered, because it'll be directly in partnership with delivery systems, and the intermediary of this insurance company, which they don't provide any care, by the way, will start to break down a little bit. And we're starting to see that now. Anyway, just my 2 cents. But there's a lot of innovation that can happen on the self-funded commercial market. Really, businesses that these board members on this call help oversee. A lot of that innovation is out there, and companies like Intermountain are ready to really engage.
Great, thanks for that. Before we move off the innovation topic, and again, there's so much exciting stuff that we could cover there. I do want to just at least try to touch on some of the we've been talking about sort of some of the traditional, obviously, players and providers. Tritra, you alluded to, Infosys, which I don't know that any of us would sort of think about necessarily as a healthcare company, but they've got this really interesting app. So I want to just ask if, for any of the panelists want to weigh in on just some of the, new, maybe non-traditional, let's call it disruptors, to use maybe an overused phrase, who are coming in, seeing the opportunities, seeing the challenges, and wanting to get to make a difference. I think maybe all of us have seen the emails, the outreach from Amazon's getting into healthcare. They've got a pharmacy now. Mark Cuban did something similar. So we'd love to just get any of your comments on what are some of the maybe most interesting kind of non-traditional competitors that are maybe coming in to do some creative disruption.
Yeah, I think tech is coming in everywhere, as we discussed, right? There are many companies that are in mental health. There's Apple Watch, there's Fitbit, Google bought Fitbit. Interestingly, though, Fitbit's service has gone down, in my opinion, as a very long time user since Google bought it, which I think underlines one of the key opportunities and risks when it comes to technology in the healthcare space. I think there's an enormous amount of benefit that is coming from it, and that will continue to come from it, very much in the way that Mallory and Dan described, which is you can get data without a person in the loop, then you bring in a human, and the net value is much higher. But there's a risk as well. And as a technology person, having spent 8 years at Salesforce and many more in the startup environment, I find myself looking as a board director through both those lenses.
I'm super excited about the innovation. There are really cool ideas that are funded, getting venture funding or private equity funding, in small scale, they're proving their worth, whether it's, taking there was a craze about a year ago of continuous blood glucose monitoring, the patch, the button on your arm, to have individuals take responsibility for an ongoing monitoring of how their, blood glucose is reacting to diet, and how diet therefore could play a better role in managing metabolic disease. That's the underlying, evil of lots of things that we're fighting today. Or the Fitbit or the Whoop, I've got a Whoop on, that's giving me information, et cetera, et cetera. I think there's stuff everywhere. Right now, it is disconnected, unintegrated, potentially just noise in the system. And the magic is going to come from being able to connect really great innovation into a system of care that really helps people get healthy. So the kinds of innovations that Dan was talking about with Intermountain, to say we're gonna play an active role in managing the continuum of care, managing the journey of care, journey of health for our populations that we serve. They're doing that through their health plan. They're doing that in lots of different ways in the way that they think about the care delivery model. It's the integration. So I think there's exciting things everywhere. We've got another step to get to. One of those steps, I'll just put it on people's radar, unique maybe to to me, since my job is strategy and transactions, is that there are transactions everywhere that are going to have to take place in order to make that a reality. We've got to rethink the boundaries of what we have historically thought of as healthcare. Right? We've got to reach into people's lives. We've got to combine payer and provider to shift the risk profiles. We've got to get consumer engagement know-how inside health systems so that they look a lot more like a retail organization with the way that they engage with their consumer through technology and otherwise than what we look like today as completely responsive to somebody who's walked in asking for sick care. So there's lots of reconfiguring that's going to have to happen structurally in order to get to the promise of all of these innovations. But I think we ought to welcome the disruptors. I think we ought to welcome the private equity players, the tech companies, the Amazons, the whoever they are, the Best Buys, who are saying, look, we're going to go play in this space because we see a need and we think we've got something of value. Now, how do we then harness that into a system of care that's going to really move the needle?
Mallory, not to imply that I'm not very optimistic as well. I've just been around the tech business long enough. I come back to that framing of move fast and break things. I'm pleased to see that more and more people are talking about responsible AI and how they approach, data privacy and other elements of this. But that's the one caveat I would have is as this moves forward, the unconscious bias that you keep hearing about. I read a recent article that was in JAMA, and Harvard published it to say that they studied people who were getting messaging from a, $50,000 population with their doctor's office and found the white folks tended to be responded to by their doctor, and the Black and Hispanic folks actually tended to get the assistant or the nurse or somebody else. And they said they needed to dig a lot harder into the data to really understand if there were other elements. But I think that's, an example when I say I'm wildly optimistic, but as you say as well, that whole responsible AI approach to how we go there is going to be very important.
Critical, for sure.
Yeah, and that relates to a question actually, I see from Brenda in the chat about, and Chitra kind of speaks to what you just mentioned. So curious, panelists, what you're seeing around, there's definitely a lot of excitement around some of these digital first and AI driven models, but what are you starting to see companies do to be able to build some of that trust?
Look, Robin, I welcome folks coming into healthcare and helping us try to figure this out. We publish every day internally at Intermountain a market scan. We do it 5 days a week, 52 weeks a year of what's happening in the market. And it's interesting. I remember several years ago, there was a lot of hand wringing when Amazon, Berkshire, and JP Morgan came and said, we're starting Haven. We're going to transform everything. Mallory, Chitra, I know you remember that. And then it was Walmart's coming for our business. And then it's, Village MD and all these new models. And what's been interesting is there's not a single one of them that has actually been able to get past this first. It's really easy to diagnose somebody who has a sinus infection because the questions are really easy and the intervention's easy. You write an antibiotic. But the moment it becomes more complex, these models, including Amazon's model, it is really an inch deep. And where people are really getting lost is, oh my gosh, I've got an issue. And the coordination out after that becomes, the interface is slick, but the moment you need complex care is the moment you're thrown back into the pool with a whole bunch of other people scrambling to find that similar care. And nobody has figured out a wire really clear care journeys for somebody who's shows up in a digital interface and then all of a sudden becomes really complex really fast. That's where people really need it. And that's where we've not seen a single solution out there. And a lot of these tech players are coming in on a point solution. They want to solve mental health. And they have, a very simple mental health app. But there's a whole bunch of things that tie into mental health, including metabolic disease that need to be managed in a different way. And so the tools and the levers that it's not like banking where there are a set amount of transactions. There are literally 5,000 conditions that drive 95% of healthcare delivery. And those become really, really complex. The diagnostic is more complex than just asking a few questions. I do think the real promise, though, is this, that the large health systems, you know, have the necessity to change what they do. And I'm seeing more and more cooperation among these health systems just to do simple stuff like agree on what a common data language should look like so that we can actually have a patient-facing medical record that's portable, where you don't have to go and try to cull together insights from 5 different providers you saw, but you've got something that where you've got a common record and an AI algorithm is helping train based on all of your medical interactions, building a customized care plan for you. And that is really easy then to interface with specialists across the board and have them have visibility to your care plan. Those are the types of things that are really going to require the large integrated delivery systems with the data sets to lean in and work together on. And I've been, in the last few years, seen more progress along those lines from the large integrated systems like Kaiser and Intermountain and Banner and others, Emory, to say, really, the large systems are the only ones who can really fix that. When they do, these digital tools, these disruptors, these new models will accelerate, I think, faster than anything else. But as it is right now, this is not a traditional startup environment. The institutions themselves, it's going to require their full participation to change healthcare delivery. And I think now realizing that the old model is breaking before our eyes, it kind of reminds me of the old Ernest Hemingway quote from the book The Sun Also Rises, where two of the people in the book were talking with each other, and one asked the other, "How did you go bankrupt?" And his friend responded 2 ways, gradually and then suddenly. And I think for the last 40 years, we've said healthcare is unsustainable. And now it's really unsustainable. It's now we're at the suddenly part. And it's in that necessity of invention that the large health systems like Intermountain and others are saying it is really, really finally time to reshape all of this and to do it not just in our own area, but with other large systems of stature to really make a play for what healthcare needs to look like going forward. And it's a really fun time to be in healthcare because I don't think you could have made these changes that we have to make 10 years ago. There wasn't the urgency and the necessity to do it. So I guess I would say, I think you'll see more internal disruption from the existing incumbent players partnering with technology in a new way than an external in, because the external end is just so complex and they struggle, and there's enough, frankly, moats around the current model that you could really stiff arm them if you wanted to. But now I think the healthcare systems are leaning in a totally different way.
I'm gonna, if you'll let me, Dan is so compelling. I don't know that he needs underscoring, but I'm just gonna tie it to one of the questions from the chat if I can, and underscore point. I, like Dan, believe that the difference will be made by the large health systems. Large health systems partnering with technology, large health systems partnering with retail, large health systems partnering with payers. And the point I wanted to underscore from the Q&A, I don't think it's going to come from the payers. Where we've got to, as a corporate community, is to push the players to allow this innovation, to support this innovation through funding. Because if they insist on staying in the existing reimbursement models, then the large health systems won't have the economic freedom to do the right thing. So, Dan, very well said.
Yeah, and I maybe just say, we say it this way. As we look, we've got Intermountain has about $16.5 billion of revenue that comes into our company a year. $5 billion of that is fully capitated, meaning we take the premium risk, we just receive a payment. And in that $5 billion, we have the freedom to do things now in a totally different way. But if you continually are paid transactionally, you cannot build a new model. And the tools that the payers use are cut your rates and question everything you do. It is really difficult to innovate in those models. So when we move to subscription models, and I saw a comment here in the chat, the subscription models we're looking at are, how do you take a primary care subcapitation? Let's just take all your spending on primary care today and work that into some sort of a subscription. And what we can do then is, under the freedom, our primary care model will look totally different. It's probably not going to be the similar set an appointment, come and see a single doctor, spend 30 minutes with them. It could be totally different the employers are spending the money. It's just they're spending it on really transactional interactions that are late in the game for most people who are already too sick to make a difference. And I think that that is going to be with the employers, with the providers directly, and not through a payer, Mallory, because again, the tools the payers have are quite limited to change how healthcare is delivered.
Great, thank you. Couple questions around, so I want to touch briefly on some of the questions about confidential data and sort of, again, that trust in some of these new models. So if everybody's got a quick comment on that, and then I do want to make sure we have some time to talk about bringing this to the boardroom. But any thoughts about, so one question around, leveraging confidential health data from individuals to feed into AI models. Chitra, you already mentioned the bias point, which is an issue. And so how are patients gonna get comfortable with that?
Yeah, I think that what Mallory mentioned about the large medical systems, the health systems needing to work with technology is a very key one here, because there is all this data that right now there are issues of trust. There's data privacy is, of course, as we all know, a huge thing. And so I think it's important that data privacy is front and center, but there are new technologies that are coming out, like using blockchain to allow for decentralized management of data. There's a lot of AI solutions that do anonymize data already, so that when they are brought together, you can remove elements of confidential information about the person, but still have enough data to be able to come up with solutions. Robin, as you mentioned, the bias situation is a very real one when it comes to training a large language model on existing data that's out there, that whatever human biases existed, of course, are reflected in the data. But increasingly, a lot of companies are building AI models that are guardrails for your first AI model. So if your first AI model is doing something, you don't necessarily need to have a reliance only on a human to find where their biases, but they're actually building counter AI models that can go in and question where you thought there might be bias. So there are definitely solutions in the pipeline now to try and manage against it.
Great. And one other thing I'd add, so thank you, Chitra, for that. I was at a roundtable the other day where we were talking about what's happening with AI. It's, as we know, it's definitely front and center on board agendas. And, while the regulatory environment is pretty complex and pretty all over the place, starting to see at the state level, some examples of regulators in numerous sectors, including healthcare, but also education, financial services, other sort of areas where they're, putting guardrails around to say, around disclosure and around how are humans going to be involved. I think Dan, was either yourself or Mallory saying, making sure that there's a human in the loop. And so, that may be one of the ways, in addition to what Chitra added, to help with sort of, building trust as we all work into this new, this new AI world. So I do want to make sure we have a little bit of time on thinking about, and we've been talking about, the role of the board off and on throughout the conversation, but do want to sort of focus on that and just ask, again, welcome any of you to weigh in. What questions, in addition to what we've already talked about, what additional questions should the board be asking the head of HR, the CEO, in order to get comfortable with, is our company well prepared to be navigating, this quickly transforming healthcare landscape, and make sure that, our employees are going to be, are going to be taken care of in the best way. And is there information that the board should be asking for? Are there metrics that the board should be seeing?
And Robin, maybe what I would say, and look, I serve on 6 boards and I chair 3, and so I kind of have both hats. And then I also sit on, I'm with the Intermountain Board, and it's been really interesting that people who bought healthcare, it's seen as a cost, and it certainly is. Obviously, it's a cost. It's a benefit you provide. It's largely been lumped in with HR, and HR people are lovely and they're wonderful. And they usually, it's so complex, they rely on consultants. And the consultants, brokers, et cetera, kind of help them navigate the system. But it's rarely, and there are some HR leaders out there that are really, really thoughtful and really strategic. But I'll tell you, I really think it requires a board. If you think about this next 15 years, the largest demographic shift in the history of humankind, a strain on labor like we've never seen before. Really figuring out how to keep your workforce healthy and to keep them engaged and keep them well is fundamental to your strategy. It has to be. Otherwise, you just can't, you can't build around your people. And so and HR has been kind of tricky. They've always tried to say, look, we get into chronic disease management about how do you balance privacy for your own caregivers or your own employees? We call everybody who works at Intermountain a caregiver, your own employees, and yet at the same time try to help them stay healthy. And there's always been this weird tension there. I would, if I were an employer, if I were a board member, I would be asking, okay, what are we doing to really drive the primary care, screening, access, that type of that equation? That's actually the lowest part of the cost. Look, a type 2 diabetic, somebody who has type 2 diabetes is not expensive when you're managing their pre-diabetes. They're expensive when you have to cut off their legs and put them on dialysis and do open heart surgery on them. That's when they become expensive. A lot of the stuff, if the boards can focus on, okay, what are your wellness plans? What are your engagement plans? What are you doing to create the right kind of preventative access, primary care access, mental health access? Much of the work is done on making sure you have the right hospitals in your network. Well, that's important, and it's not going to really help you move upstream to keep people well. So I think the more the boards can lean in to say, you know, what is your plan around building programs for people with hypertension to make sure they're on their medication? What are the programs to make sure that when a new change on the colonoscopy screening guideline, which by the way saved my life when they changed it, that people are aware of that and you're actually applying that to your group. I mean, it really is about, when those conversations happen, they almost happen about cost. What were the high dollar claims? Who ended up in the hospital with a heart transplant that we ended up having to pay for? But if you think about the longitudinal health of your people, it should be, what are we doing to engage people in preventative medicine way earlier? And what's our long-term plan? We're investing in a whole bunch of retirement benefits for these people, but if they're too sick to work, that's not going to help us. So I do think the boards can help lean in that way, in a different way, and provide maybe a different lens for the HR teams and leaders to look through. I think that would be a help.
Terrific. Chitra and Mallory?
Yeah, Robin, it's
Questions?
interesting what Dan mentioned about looking at the cost and how you look at the cost, because I mentioned earlier in technology, when you're a company trying to buy technology, you look at total cost of ownership, right? Which actually gives you all the puts and takes. And that's the way, as Dan said, that people need to think about as directors. You need to ask for what is the financial sustainability of your healthcare model in terms of how much is it costing? Are you monitoring the outcomes? Is that having an effect on your workforce? Because human capital has floated to the top as one of the biggest issues that comes in front of a board of directors, because again, the long-term sustainability of the company is deeply dependent on human capital. So if you look at total cost of ownership, as it were, which then brings in the preventive aspects and therefore the net savings to your company beyond just the cost of healthcare, but actually in terms of productive hours spent in making your company better, I think that is really the way to think about healthcare, the way people think about technology.
Love that. Mallory will give you the last word.
Well, I think that they've given such great advice here already. I'll push one step further, and then I'll actually wink at Dan and make sure that I'm not volunteering him for something he doesn't want. So many of the people on this call are from Utah, and obviously Intermountain has a really great presence here in the state. I think in addition to pushing the benefits design pushing the brokers to say, how are we thinking about preventative care? Asking about data on the preventative care and the health status of the employees at your at the businesses where you sit on the board. I think maybe reaching through and past the brokers to the local care delivery institutions to ask about how do we partner. You know, could we do some things around corporate health, around executive health, that really come into our business and help us think about creating a healthier population from the care delivery angle, rather than from only through the broker and insurance and benefit design angle, might be a really interesting push.
Great. Thanks. And I also want to give a hat tip to a couple of folks in the chat who suggested questions that the boards could ask. So what percentage of our employees are getting their annual preventive wellness check? That's a question that the CHRO could bring back to the board, and also benchmarking care plans against successful companies against Chitra's total cost kind of frame. And I see here another question to ask is, you know, how are we instilling employee accountability? We talk a lot about that with you know, awareness and training with things like cybersecurity, and everybody's on that. Now AI is coming in there. What about you know, what about some of these other areas as well? So I think with that, we've covered a lot of ground. Please join me in thanking our terrific panel, Mallory, Chitra, Dan. It's been great. Thank you for being so generous with your time and your insights, and really appreciated the questions and the perspectives in the chat. We have there are a couple of resources. If you didn't see them, they came out in the email from NACD, but a couple of articles. So if you haven't seen those, definitely take a look. And with that, I will hand it back to Mark to wrap us up.
Great. Thank you all panelists there. And Robin, you too. We really do appreciate you organizing this and moderating this for us. It was a terrific program. We would like to get your feedback on the program. And so there is a link, will be a link in the chat room to a survey, and you will also get one by email. So if you could take a few minutes to fill that out, it helps us continue to give you quality programming. Our program season ends at the end of June, and we have one more event being scheduled, and that is on Tuesday, June 18th. It is virtual, and it's the title is The Latest Trends in Organizational Compensation and Incentive Structures. So we'll be talking about both public company and private company compensation programs and what the trends are there. So keep an eye out for that. And then our new program season kicks off in September, and we have a very exciting event in Salt Lake City on Thursday, September 19th. We are doing a fireside chat on governance with our former governor, Mike Leavitt. And that will be followed by an optional tour that Mike will give us of the Tabernacle Choir facility. So keep that on your calendars for September 19th, and watch our website for more news. Okay, that's it. Thank you all for attending. We appreciate your participation. And again, thank you to EY, the panelists, and Robin Bew as well. Thank you.